Once you just 8:35, you start. Whatever we can do, we do. What we can answer together, we answer together. What we cannot answer, we'll move to the next one. If we keep waiting for people, they'll be coming by 8:50. But once you see that we start early, they will realize that they've missed a lot, so they will come early.
So Chief Okobi, please, you will start now till Chuka comes in. Probably I'll be done in the next 45, 1 hour with my Oga, then I'll come back. But I've already started recording the meeting already.
All right, good evening, everyone. We would start with the orals. I think we have a couple of persons here, and the questions have been distributed. So the floor is open. Today we'll be taking orals. Dr. Jacqueline, Fatima, I think you guys have some questions. Let's check if anyone is ready. So I think we have a question for Dr. Jacqueline. Discuss in detail the procedure of performing a myocardial biopsy, states its indication and complications. Maybe before she finishes, we'll have others on the call. Or Dr. Fatima, I don't know if you guys saw the orals as it was distributed. Dr. Fatima, okay, so after Dr. Jacqueline, then we may take that of Dr. Fatima. So the floor is open. Let's keep the ball rolling. Thank you.
Okay. Good evening, senior colleagues and colleagues. I'll be discussing the endomyocardial biopsy. So trying to share my screen. Can you see my screen?
Yes, I can see the screen. Very nice. Thank you for going this far.
Okay, so thank you. Okay, so the question reads, discuss in details the procedure of performing a myocardial biopsy, state its indications and complications. So briefly, the definition of myocardial biopsy is actually a procedure that is used to obtain myocardial tissue to monitor for the occurrence of, basically, that's the primary indication, is to monitor for the occurrence of allograft rejection after cardiac transplantation, or less commonly, it's used to diagnose diseases of the myocardium. So the indications for endomyocardial biopsy, we have the class 1 indications as well as the class 2A indications. So the class 1 indications, you can divide it into that for transplanted hearts, as well as that for native hearts. So for a transplanted heart, which is the major reason why a myocardial biopsy is done, is actually to monitor for rejection post-cardiac transplant. And then for the native hearts, the indications, the class 1 indications are to identify possible presence of fulminant myocarditis or giant cell myocarditis that will actually benefit from giving this group of people immunosuppressant therapies. So typically the clinical scenario that meets the criteria, that meets the class 1 indication for endomyocardial biopsy for a native heart, is for someone that has a new onset heart failure, less than 2 weeks duration, associated with a normal size of dilated left ventricle and hemodynamic compromise. Or someone that has new onset heart failure, 2 weeks to 3 months duration, associated with dilated left ventricle and new ventricular arrhythmias with second or third degree AV block, and a failure to respond to usual care within 1 to 2 weeks. These are the primary class 1 indications. So for people that, for the class 2A indications, the indications for endomyocardial biopsy in this group of people are people that have heart failure greater than 3 months duration that is associated with a dilated left ventricle and new ventricular arrhythmias, similar to that in the class 1, except that in this group of people, the heart failure duration is greater than 3 months. Also, is indicated in people that have heart failure that is associated with DCM of any duration with allergic reaction or presence of eosinophilia, or people that have heart failure with suspected anthracycline cardiomyopathy or unexplained restrictive cardiomyopathy. Also, for people that have suspected cardiac tumors, we want to do a biopsy to know the exact type of cardiac tumors that the patient has. And in children that have unexplained cardiomyopathy, these are the class 2A indications. Other indications for endomyocardial biopsy are actually not, that those ones fall under class 2B indications, and it said that the benefit of doing myocardial biopsy for this group of people is not established, so generally not recommended. But for us to take note of that, the major indication is for to identify transplant rejection. So for the procedure, the major thing that is used to obtain the biopsy material, that the biopsy sample, is a bioptome, and this is a picture of a bioptome. So in still a picture of a bioptome. So in preparing the patient for endomyocardial biopsy, the surgical equipment are assembled. The surgical equipment actually include this one: Gans catheter, endomyocardial biopsy forceps, as well as the other materials that will be used, the surgical materials that also be used to gain access, a surgical blade, the guide wire, and all that will help to gain access into the patient's heart. Also, staffing is important in the procedure. The cardiologist is the person that carries out the heart catheterization and the biopsy collection. And he has an assistant that helps to measure hemodynamics, because it's recommended that before the biopsy is done, the right heart catheterization should be done, and the pressures in the different parts of the heart should also be measured. Additionally, it's also said that blood samples for blood gas analysis can also be collected. The nurse is required as well to prepare the equipment and also record hemodynamic data that is collected during the procedure. And then a cardiac sonographer will help to visualize the heart, because it's been said that in most cases of endomyocardial biopsy, that an echocardiograph is usually sufficient enough to visualize the heart and help to prevent complications in this group of people. So a patient that is undergoing endomyocardial biopsy, you can do it under fluoroscopic guidance, you can do it with echocardiography, or sometimes both imaging procedures are actually used to help visualize the heart and prevent complications that may arise. Typically, a right heart catheterization is done biopsy the myocardium, because it said that most of the diseases of the heart can be diagnosed actually from the right side, and it's only on rare occasions that a left heart catheterization is done, especially in cases of left heart tumors, or where we think that the disease is actually the left side of the heart. So what happens is that the patient is, after the patient has been brought into the cath lab, the patient is positioned fine without pillows, and the head is rotated to the left. The triangle vertex of the sternocleidomastoid muscle on the right side is identified, and the area is sterilized using the whole sterile technique to clean the area, and then the patient is appropriately treated. After this, the patient is given 1% lidocaine to achieve local anesthesia, after which the site is punctured. Typically, the right internal jugular vein is used, but occasionally the left internal jugular vein may be used. Other veins that may also be used are the brachiocephalic vein, and occasionally femoral vein may be used. In the case where a left heart catheterization is done, it's usually a femoral artery that is punctured. So after access has been gained into the right side of the heart, the bioptome is advanced into the heart. The bioptome is advanced past the right atrium, and then while passing the tricuspid valve, it's said that it should be rotated slightly counterclockwise. This enables it to pass more easily into the right ventricle. And when the bioptome is advanced into the right ventricle, usually should be done under fluoroscopic or echocardiographic guidance. It should be advanced towards the intraventricular septum. While it's been advanced towards the intraventricular septum, it should be ensured that the bioptome jaws are closed. This is so as to prevent perforation of the ventricle in the process of advancing it. So when the bioptome is advanced and it makes contact with the interventricular septum, the usual things that will show that it has made contact with the interventricular septum are that you can now see evidence of premature ventricular complexes on an ECG. You might find that there's resistance. In fact, it's expected that there's resistance to further advancement of the bioptome. And then there's a device transmission of right ventricular impulse. That is, you can feel the on the bioptome, you can feel the ventricular contraction. So that will tell you that you've put it at the right location. So now when you have made contact with this interventricular septum, you now pull the bioptome slightly backwards. When you pull it slightly backwards, you then open the jaws of the bioptome. Like the picture I showed, it showed that the bioptome has two jaws. You open the more like the mouth or the jaw of the bioptome, and then you re-advance it to make contact with the interventricular septum again. Then you close it. When you close it, you pull it back and take it out from the heart and put it into the solution that has been kept to receive the biopsy sample. So you rinse the bioptome in warm saline, and then you put it in heparinized solution. The essence of doing this is to prevent thrombus formation that may complicate the procedure. When you've done that, then you re-advance the bioptome. In collecting the biopsy sample, we expect that the biopsy sample should be pink, because that's what the myocardium is expected to look like. So if you see a white colored sample, it means that we have biopsied the fatty tissue or a tricuspid valve leaflet. Then additionally, it's expected that for each biopsy procedure, you take about 4 to 6 samples, and each of these samples should measure at least 1 to 3 millimeters in size. And then for patients that have conditions like sarcoidosis, electromechanical mapping may actually help to locate the areas where the abnormal tissues are, so as to know the right location to biopsy. It just shows a picture of the biopsy that is being done. So what are the contraindications? The contraindication for endomyocardial biopsy are presence of intracardial, that's the absolute contraindications are presence of intracardial thrombus, because this would cause complications in the procedure, ventricular aneurysms, as well as the severe tricuspid, pulmonary aortic stenosis. Patients that have aortic and tricuspid mechanical prosthesis. Then relative contraindications would include people that have active bleeding, infection, and fever, and also presence of infective endocarditis, coagulopathies, and the contrast media hypersensitivity, and also a patient that is uncooperative. And then finally, what are the complications of the procedure? The procedure may be complicated by the process of advancing the bioptome, or even during cannulation. It may be during the biopsy process. So the possible complications that may arise are hypopericardium if the septum is perforated and the entrance and there's the communication with the pericardium. Tamponade may occur, and then mediastinitis may also occur. Patients may develop pneumothorax. There might be air embolism, pneumopericardium. Thromboembolism may also occur during the procedure. So that's why it's essential that the patients, we try to limit the possibilities of thromboembolism by using the heparinase solution to raise the biopsy. Myocardial infarction may also occur during the procedure because the coronary arteries may be perforated, and there might be a fistula formed between the coronary arteries and sometimes the ventricles or even the other vessels, and this may lead to a myocardial infarction. Transmission of infectious organisms may also occur, and there may be damage to the tricuspid valve. This increases, especially this risk increases, especially in people that already have stenosis valves. Other complications that may occur that may be minor are presence of chest pain, ECG abnormalities may occur, and they're usually transient. Nerve damage may also occur, and then there may be rupture of the caudate tendinae during the procedure. Either the caudate tendinae may be inadvertently biopsied during the procedure. Hematomas may also occur, hypotension, deep vein thrombosis, and vascular fistulae. Thank you.
Thank you so much, Dr. Jacqueline. Very, very detailed and impressive presentation. Please, if there are questions, let's take them, and contributions. The floor is open.
Okay, it's like Okopi have gone, I've dropped out of the call. So there's silence of the graveyard. So I don't know, it's either we are all very comfortable. We do not have anything that we need to seek clarification of from Dr. Jacqueline. We have become more confused that we don't know how to start. So I think we can seek for clarification. Sorry, I personally joined a little bit late. I was engaged. I've been on call, so let's ask question. So we'll be better informed when it comes to myocardial biopsy. was so detailed. So any question?
Well, thank you very much. I'm sorry I had some issue with my computer. I couldn't join, but I missed the presentation. Dr. Jacqueline, well done. I know it was actually a very good presentation, even though I didn't hear anything because I wasn't able to join. So please, can you just display the slide for the indications, if you don't mind?
Okay, let me do that.
Thank you. Okay, thank you.
It's a busy slide.
Yeah.
As aside from the fact that the primary indication will be a patient that you want to identify presence of allograft rejection. That's actually the major reason why endomyocardial biopsy is done these days. It's only occasionally that we want to find out if maybe a patient has myocarditis. That's when these other indications also come into play.
Yeah, I think I agree with you. You know, with the advent of non-invasive investigative tools that are also very good, like CMR and things like that. These are some of the reasons why now the use of endomyocardial biopsy in diagnosing of disease is being downplayed, because we know it's actually an invasive procedure that is not devoid of so many complications. But that being said, there are so many diseases that basically, if you look at the ACC/AHA 2015 guideline, now they specifically mention maybe two major reasons why you go for endomyocardial biopsy, and I believe you mentioned them. The most important one is when you now want to truly confirm the possibility of allograft rejection, post cardiac, heart transplant, and occasionally, of course, in those that you are suspecting, for example, giant cell myocarditis. But the essence of doing endomyocardial biopsy, concerning the fact that it's invasive, is only when, if you do it, it's actually going to influence diagnosis and the treatment overall. Otherwise, if there are other non-invasive investigation, there is no need for you to do that. So I think I'm really happy. I only missed the presentation. I believe I could have learned more, but looking at this slide, I think it's okay. Thank you very much. So once again, congratulations.
Thank you.
Well, thank you very much, Babalawa, for your contribution. So I don't know if Okopi is back.
It's not yet. He's not yet back, sir. I don't know. Maybe his network.
Okay, so I don't know. How many are we supposed to take today?
I don't even. I don't know. As the topic being shared, I don't even know. What is going on.
Yes, the topic have been shared though.
Really?
Yes.
I don't even know. So okay, maybe we don't have to.
And
I don't even know if the topic
you're
given to
supposed
me.
to discuss the pathophysiology of heart failure with us.
Who, me?
Yes.
So okay, when?
Anytime you are ready.
No problem. So thank you. In fact, I don't even know. I have been having some issues. So okay,
if you are ready today, you can discuss it.
I'm just hearing about it, and you are telling me I'm ready. Pathophysiology of heart failure. Okay, no problem. So I have to prefer some. Okay. Somebody want to speak, Dr. Na? Or...
Hello.
Dr. Goodyear.
Okay, Okopi, you're back. Welcome back.
Yes, sir. I'll call. We have the topics in the group or the question. And Dr. Babalawa is supposed to take pathophysiology of heart failure.
Okay, sir. So Yes, sir. In fact, I'm just asking if the topic has been shared, and Dr. Godel was telling me that I was supposed to take part of the heart failure, but pardon me, actually, I'm not even aware, but I will try and see if I can get ready and present my own tomorrow.
Okay, perfect. So there we go to Dr. George Pepra. Dr.
Thank you.
George Pepra.
Hello. Honestly, I'm
Yeah,
also just checking. When I heard Dr. Babalawan talking about it that he hasn't, I just opened it myself and realized I also
okay.
honestly I didn't see. I'm sorry. I'm not
All
prepared.
right. All right. Okay, there's no problem. Let's have Dr. Abdurazak if he's on the call. But meanwhile, I want to say a very big thank you to Dr. Jacqueline. Always reliable, Jacqueline. Thank you. We'll have your slides on the page soon, I guess.
Okay, thank you.
So, Dr. Abdurazak. Dr. Abdurazak, please, it's over to you.
Hello, Chief.
Yes, sir.
Chief.
Yes, I
Hello?
can hear you, sir.
I thought we are on the MCQ.
We can hear you, sir.
I thought we are on the MCQ section. I don't know that we have entered the theory part. So,
Oh, okay. So sorry, but we had a meeting that Tuesdays and Wednesdays will take orals, while
okay.
Mondays and Thursdays will take the MCQ, so as to have a blend from time to time.
Okay. I didn't see it on the WhatsApp page. Yeah, sorry.
Okay, I'll repost it again so that everybody can have theirs. Okay, Dr. Okogun, I don't know if you saw yours. What is resistant hypertension? When is it regarded
Dr.
as
Okopi.
refractory hypertension? Yes, sir.
Dr. Okopi. Dr. Okopi. So,
Yes,
Dr. Okopi. Sorry,
sir.
I think I'm still. I'm trying to. I just opened my WhatsApp, and I can still. I can only see the names, but not the topics. Truly. So if you can,
Okay.
you understand, I can only see the names, our names.
Okay, let me post it again.
So
I just sent it.
Hello?
Can you see it?
Yeah,
Can you see it?
my part.
Okay, Fatima is ready, so no problem.
Okay, Fatima, please go ahead. Dr. Brazza, please, can you mute yourself? All right, good. Dr. Okogun, too. All right, Aisha Agodia, please, can you? Okay, Dr. Fatima, over to you. Thank you so much.
No, it's my screen
Okay,
that's showing.
Okay, Okogun is ready. So after Okogun, we'll take Dr. Fatima.
All right.
So good
Dr.
evening.
Copy. Dr. Copy.
Yes, sir, I can hear you, sir.
I think we have invited the seniors to be around. So when we discuss a particular topic, I think
Okay,
we should give them some time to
yes, sir. Yes, sir.
to direct the presentation for us. That
yes, sir.
so, yes, sir.
Yes, sir. I'm trying to find any of the seniors. I'm yet to see one, sir.
I think.
Okay, so I don't know. I guess I can move on.
Okay, just go on. Just go on. If they come on, I'll let them have the stage to talk.
So I'm asking question 4B of the report for. So the questions are: what is resistant hypertension? When is it regarded as refractory hypertension? And what steps will you take to manage it? So resistant hypertension is defined as high blood pressure uncontrolled, that is above goal, with 3 different classes of antihypertensive at maximum tolerated doses or recommended doses, or when blood pressure is controlled with at least 4 antihypertensive drugs, including a diuretic. So, not achieving control at according to your targets with 3 drugs, or you're having to use 4 or more drugs, including a diuretic, to control blood pressure. This was defined as resistant hypertension. And HACC and ESC have a consensus on this definition. Then I just look at different subtypes of resistant hypertension. There's apparent resistant hypertension and refers to all categories, because there's actually true resistant hypertension and pseudo-resistant hypertension. So all causes of resistant hypertension are under apparent resistant hypertension, and about 8.9% of patient hypertension in the US are said to have apparent resistant hypertension. But true resistant hypertension refers to resistant hypertension with no known cause or apparent cause, and about 45% of resistant hypertension are true. And pseudo-resistant hypertension, you can actually find.
Sorry, Dr. Okogu, I don't know if you are talking with earpiece. It seems the voice is okay. We're a little bit losing you. I don't know if it's just me.
Okay, I'm using my earpiece on my phone, but this thing is on my laptop. Maybe I should use my laptop.
Okay, all right. Okay.
Let me put this earpiece on my.
Better. We cannot really hear you, sir. Thank you.
I don't know if it's better.
It's better now, but it's driving.
Am I audible now?
Yeah, you're audible better now. Very good. Go ahead, sir. It's better now.
Hello?
It's better now, sir. You can go ahead.
Yeah, we can hear you, sir.
Is it clear, sir?
It's very clear.
Okay, let me continue. Where are we?
Maybe if you can start from the beginning, sir, because we couldn't hear you at all.
Okay, so I'll start from the beginning. I said these are the questions. What's resistant hypertension? When is it regarded as refractory, and what steps should you take to manage it? And I said the consensus definition, AHA, ACC, and ESC, is that resistant hypertension is defined as high blood pressure uncontrolled. That is not meeting your target goals, with 3 different classes of antihypertensive at maximum tolerated or recommended doses, or blood pressure controlled with at least 4 antihypertensive drugs, including a diuretic. So lack of control with 3 medications at maximum tolerated or recommended doses, or control with 4 or more drugs, including a diuretic, is what defines resistant hypertension. And I said there are different ways, there are different aspects to it. All categories of resistant hypertension can be referred to as apparent resistant hypertension. And about 8.9% of people in the US with hypertension have this. Then true resistant hypertension is when you cannot find any cause, because there's about 45% of patients with resistant hypertension. There is pseudo-resistant hypertension, when you can find an explanation, as we'll discuss later. A patient, for instance, is not drug compliant. He's on 3 drugs, but he's not compliant. So it's pseudo-resistant because it's compliance issue that is causing the apparent resistance, whereas it's not really resistant, truly resistant. Then resistant hypertension is associated with high prevalence of secondary hypertension, and they also come with worse cardiovascular and renal outcomes. Also, it comes with increasing age of population. 13 to 20% of adults in the US, and half of these patients, 50%, have pseudo-resistant hypertension. So what are the causes of pseudo-resistant hypertension? Improper BP measurement techniques. So the person, whoever is checking, whether it's the patient or the medical personnel, is not properly taking, either is using an inappropriate cuff size, or positioning, or the 5 minutes rest required, or posture, not placing this, the guidelines for taking BP is not followed. So that may give you falsely elevated blood pressure. Also, the non-pharmacological measures for BP control, like diet, salt, and all of that, if the patient is not keeping strictly to them, it may also be a cause of pseudo-resistant hypertension. Then white coat reactions. Patients who just develop white coat reactions, their blood pressure shoot up in the hospital because they are not because of the doctor, and then sometimes recommended that either a nurse or someone else who is trained does it so that the doctor effect can be removed. So that can also be a cause of pseudo-resistant hypertension. So when these patients get back home, their BP is fine, or better control. So white coat reaction is thought to be responsible for up to an increase as much as 12 millimeters of systolic and 9 millimeters of diastolic. Medication non-compliance is also a serious issue when it comes to pseudo-resistant hypertension. The use of co-administration with NSAIDs, excess alcohol use, psychiatric medication can also antagonize antihypertensive and make you look resistant. Of course, if the doctor has not done his due diligence in optimizing the regimen, that can also cause that. Clonidine rebound, inadequate diuretic therapy, also inappropriate use of low diuretics in patients with normal renal function, infrequent dosing with short-acting low diuretics, for instance, patients furosemide daily instead of twice daily, or low dose HTT in impaired renal function where you are supposed to use higher doses, can all account for pseudo-resistant hypertension. So they are false resistant, they are not true resistant hypertension, because if you correct these things, the patients will probably be controlled on 3 or less. So that takes me to the next question. When is it said to be refractory hypertension? Resistant hypertension that's not controlled even with maximum medical therapy. That is 5 or more drugs, including clothalidone, which is a choice or first choice diuretic, and a mineralocorticoid receptor antagonist under the care of a hypertension specialist. That's the definition. That's the up-to-date definition, and I didn't say something contrary. Resistant hypertension not controlled even with maximum medical therapy, requiring 5 or more drugs, including clothalidone and MRO antagonists under the care of a hypertension specialist. And it's about 3% of those with resistant hypertension, and may actually be due to neurologic mechanism like sympathetic overactivity as a cause of the refractoriness of the hypertension. So no matter the amount of medications you give, the patients may actually not respond. They may not be controlled on it. So the risk factors for resistant hypertension include higher baseline BP at presentation, left ventricular hypertrophy, older age, obesity, African American race, presence of CKD, presence of diabetes. Then I mentioned other causes of resistance hypertension, including herbs that may contain things that antagonize antihypertensive. And secondary causes of hypertension, like primary aldosteronism, renal artery stenosis, CKD, obstructive sleep apnea, pheochromocytoma, Cushing's syndrome, aortic are all risk factors for that. So how do you manage the last part of the question? Counsel patients on drug compliance. You want to also take a history of the cost implication, because that might be why the patient is not buying his drug. Then the pill pack, and they may want to look at their pill pack and see whether they have actually been taking it or not, for those who insist they are taking it and whether that is practiced. Also, you want to look at the dosing, how they are taking it, and if you have given adequate dose. And then you see also how they are taking it. Is it conveniencing, a doctor tells a patient must take it in the morning, and then that's not very convenient for the patient. So you look at all those factors that may affect compliance. Then you also want to examine and look for telltale signs of secondary causes of hypertension. Then you want to do the following investigation: electrolyte, random blood sugar, urine albumin creatinine ratio, plasma aldosterone. I think that should be aldosterone. So, and plasma renal activity. Yeah, plasma aldosterone concentration and plasma renal activity. because, and then you want to calculate the ratio of plasma aldosterone concentration, plasma RNA activity in making a diagnosis of primary aldosteronism. So you also want to do a 24-hour urine sodium. When the values are high, so unfortunately I didn't note the cutoff. When the values are higher than normal, it may suggest that the patient is not compliant with the low salt diet prescription. We also want to do 24-hour aldosterone excretion when you're looking for primary aldosterone is a renal Doppler scan for renal artery stenosis. You also want to ensure adequate and appropriate dosing of medications as your own part of it. And then, of course, patient also is compliant with that. They want to screen for use of pressure agent and white coat effect. So use of pressure, you look at what other drugs the patient is taking along with the antihypertensive that may be counteracting or causing a drug-drug interaction. And white coat effect, ambulatory BP measure should be able to help you make a diagnosis of that. And you want to look for secondary cause of hypertension, CKD, pheochromocytoma. Then if no cause, you want then add a mineralocorticoid antagonist. You can do low dose blocker as further measures to control this, discussing resistant hypertension now. And then, of course, lifestyle and dietary measures ensure they are enforced. So that's what I have on the questions. I don't know if there are additions or comments, questions, or subtractions. Thank you for listening.
Thank you
so
Dr.
much, Dr. Okay.
Please go ahead.
I'm just opening the floor for anyone that wants to contribute or ask questions. So the floor is open.
Okay, thank you, Dr. Okopi, for the. I just want maybe one or two additions. That of course the one of the other way to is drug refill. You can also check, especially for those that have health insurance. Maybe that will also assist to see if the patient has also been taking the medications or not. And of course, I was also trying. You are trying to remember the for the concentration of the urinary sodium too. I saw in the place 87 milliequivalent per mole per mil, I guess. Yeah, 87 milliequivalent is what they usually use as cutoff. So if it's more than that, then probably the patient is taking excess sodium, and that will say why the patient is having a persistent hypertension. And those are the additions I have. Thank you.
Thank you very much, sir. Any questions, comments, please? Thank you, sir.
Sorry, Dr. Tunji, can you come back with the explanation you gave?
Oh, okay. If an individual is being evaluated for resistant hypertension, then one of the ways to see if the patient is taking excess salt is to look at the sodium concentration in the urine. And he said that if it is more than 87 milliequivalent, then that would mean that the patient is taking excess sodium, and that may just what is needed to be addressed, okay, for the patient, because excess salt intake will also be the cause of the resistant hypertension. I think those are that's the addition I need.
Okay, thank you very much.
So I don't know if any of our teachers in the house have additions or corrections or questions to make. We can take the next presenter.
Kweki, do you have anything to say so that we can move on? Hello, Kweki, are you there?
All right, since he's not around. So if in the absence of any other contribution, Dr. Koku,
I'm
please, would you
around.
be able to send us your slide?
hello. Hello.
Yeah.
Yeah.
I can hear you.
So a bit distracted. I did you talk about the management of refractive hypertension? Did you surgical intervention? I didn't get that part, so I wanted to just verify. Are you there?
Yeah, this is the management slide, sir.
Yeah, there's that last. Any surgical intervention?
For pheochromocytoma, that may be required. So that's when there is a secondary cause. When there's a secondary cause for it, like pheochromocytoma.
If you, these are secondary causes, which again can also be responsible for resistant hypertension, is it not? So
yes,
there's something you said before now that most of before this slide, if you can go to the previous slide, it's go backwards. Yes, the last no. Come back again. No, come back. Yes, no, go back. Yes, this one. The last point may be due to neurological mechanism like sympathetic overactivity. So you talk about the concept of renal, what's that?
Denervation.
Yeah. These were our questions during the exam. Professor Dan Bauchi was looking to hear that intervention. So renal denervation. That's the reason why the hypertension specialist will have to see. Although I think the syntax 2 trial also that look at renal nerve denervation. They didn't appear to find anything. The outcome of the people that were randomized into the denervation therapy didn't do better than the other people. But they realized that they had to look at the data again. So they realized that they didn't do patient selection properly. Okay, so when they now looked at the group of patients that they use, we're looking at almost every other patient. So when they now look at the inclusion criteria properly, they realize that patients that are a bit younger, less comorbidity, apparently you cannot even find secondary cause to the condition. Here they're having refractive hypertension. If you do renal nerve denervation, this group of patients, they tend to have a better outcome than the other group of people that did not do renal group denervation. Thank you.
Thank you very much, sir. I see why we need our teachers around. Thank you, sir. So I don't know if there are no other comments. We can move on to the next presenter.
Okay, there's that question. There is concept about this carotid under same surgical. I want to ask Chief if it's also part of it. It can also be discussed. Carotid.
Just carotid body stimulation.
Yes, carotid. Yes.
So there's that concept is also there. Actually, it's just to stimulate the parasympathetic in order to overcome the effect of the sympathetic. And in fact, even that one, it has also been done. Some few studies, not on the mice, management of heart failure, and they have seen some benefits. So they're now trying to see how they can at least make use of it in very larger randomized study to see the effect. But I think, maybe it's something that also say that.
Okay, thank you. So,
Thank you so much, Dr. Okoko. Please, if you can help us with the slide and
yes,
if you can include the other important statement that we added.
yes, I've already updated that. The other questions I'm answering are here. So,
Abdul Razak, please can you up your mic, Abdul Razak? Oh, all right. Yeah, Okoko, what was
okay. So, yeah, I said I'm already updating that. Then I said my other question is here. So when I finish with the second question, later on I'll just share at once because they're all on the same slide. Thank you.
Okay, why don't you can finish your both questions now? What do you think?
I know, but it's in a different. That's under the MCQ part. It's not. It's not on that. I think it's under the MCQ.
All right, so let's just get Fatima up. Dr. Fatima.
Yes.
Dr. Fatima.
Yes.
Over to you. Over
All
to
right.
you, please.
But I actually didn't prepare slides. I don't know it's supposed to be on a slideshow.
Oh, all right. Maybe after now you just put it in the slide so that close to the exam people can just breeze through if you can't go through the audio.
Oh, it's all right. I will do that.
All right, thank you. So you can go
I'm
ahead.
answering question 5B, but the information is related to the first part of the question, that is question 5A. So the information reads, the question reads, you are called to see a patient. That is the A part I'm reading now. You are called to see a patient in the emergency room with breathlessness. How will you confirm that the patient's symptoms is due to acute pulmonary edema? So they were interested from the recall, this person that recalled said they were interested in the history and examination findings in this station. So the P part said, in the patient above, how will you manage him if the acute pulmonary edema is due to acute coronary syndrome? And they said the examiner was interested in types of thrombolytic agents available in your center, how it is administered, and the dose and the indications. So my answer is flash pulmonary edema can result from myocardial ischemia with or without myocardial infarction. And management of the patient entails admitting the patient possibly into the ICU. Then the ABC of resuscitation, ensure the airway is patent, the patient is breathing, as well as maintain circulation. It is important to set an IV line, take sample for baseline investigations, the cardiac troponins, lipid profile, clotting profile, urea electrolytes and creatinine, full blood count, and the others. Then consider oxygen therapy to maintain oxygen saturation greater than 90%, especially if the oxygen saturation is low, because oxygen therapy is not always indicated in patients with myocardial infarction, except if it is on the low side. Some school authors said less than 92%, some said less than 94%. So oxygen therapy is necessary if the patient is not saturating well. Then medical therapy of cardiogenic pulmonary edema includes the use of preload reduction, using loop diuretics like furosemide, torsemide, or the use of nitroglycerin, either given sublingual or IV. It also includes afterload reduction using angiotensin converting enzyme inhibitors or angiotensin receptor blockers. However, if these strategies are not successful, that is preload and the afterload reduction, then someone may consider inotropic support using agents like dovitamin or dopamine. In a patient with acute coronary syndrome, the goal of therapy is revascularization. So as you are resuscitating the patient, it's important to activate the cardiac catheterization lab if available in the center, or you may consider thrombolysis if the patient comes with acute STEMI or high risk and STEMI. So PCI is a mechanical form of reperfusion, while thrombolysis is the pharmacologic form of reperfusion. So thrombolytic regimens include alteplase, use of alteplase, retaplase, tenecteplase, or streptokinase. Alteplase is a first-generation recombinant plasminogen activator, which is identical to the native tissue plasminogen activator, and it can be administered in an accelerated infusion, that is over 1.5 hours, 1 hour 30 minutes, using 50 milligram and 100 milligram vials reconstituted with sterile water to 1 milligram per ml. So accelerated infusion for acute MI consists of giving 15 milligram IV bolus, then 0.75 milligram per kg IV over 30 minutes up to 50 milligram, followed by 0.5 milligram per kg IV over 60 minutes up to 35 milligram. But the maximum total dose is 100 milligram for patients weighing more than 67 kilogram. Another agent that may be used is retaplase. Retaplase is a second generation recombinant plasminogen activator, which has a lower bleeding tendency than the first generation, that is the alteplase. And the way to give it is that you first reconstitute it. You reconstitute it in two parts. The first part is using 10 units vial, then the second part you give another 10-unit vial. So you could reconstitute it using sterile water, also 10 mils of sterile water, you could reconstitute to 1 unit per mil. Then the adult dose consists of 2 IV boluses of 10 units each, and no weight adjustment is needed. So you give the first 10-unit IV bolus over 2 minutes. Then 30 minutes later, you give a second 10-unit IV bolus, again over 2 minutes. But you administer normal saline flush before and after each bolus. So this is how retaplase is being administered. Then what about tenecteplase? Tenecteplase is an agent with higher fibrin specificity and longer half-life than alteplase. You also need to reconstitute it, where you mix 50 milligram vial in 10 mils of sterile water. That is making it 5 milligram per mil. It is administered in a 30 to 50 milligram IV bolus over seconds. So you calculate the dose based on the weight of the patient. Patient weighing less than 60 kilogram, you give 30 milligram, which is 6 mil. Patients weighing between 60 to 69 kilogram, you give 35 milligram, which is 7 mils. Patients weighing 70 to 79 kilogram, we give 40 milligram, which is 8 mils. 80 to 89 kilogram, you give 45 milligram, which is 9 mils. Then patients 90 kilogram and above, you give 50 milligram. As I said, the maximum dose is 50 milligram. The dose range from 30 to 50 milligram, and the 50 milligram is 10 mils. So this is how tenecteplase is being administered. Then streptokinase is the one that we commonly use because, in fact, it is the one that is widely used because of its low cost and is associated with low risk of intracranial hemorrhage. Streptokinase is produced from streptococcus, hence the reason for the fever and allergic reaction experienced by patients. So the adult dose is 1.5 million units in 50 to 100 mils of 5% dextrose water, given IV over 60 minutes. So allergic reactions may force the termination of many infusions before a therapeutic dose can be administered. Then the contraindications for given thrombolytic treatment. The absolute contraindications for thrombolytic treatment include recent intracranial hemorrhage within 3 months, structural cerebrovascular lesion, presence of intracranial neoplasm, ischemic stroke within 3 months, possible aortic dissection, active bleeding, or bleeding diastasis, and excluding menstruation, significant head injury or facial trauma within 3 months, recent intracranial or spinal injury, severe uncontrolled hypertension, and for streptokinase, previous treatment within 6 months. If it is given within 6 months, you cannot repeat the dose. So relative contraindications include history of severe and poorly controlled hypertension, severe hypertension at presentation where the systolic blood pressure is greater than 180 and the systolic greater than 110. Prolonged more than 10 minutes cardiopulmonary resuscitation or major surgery within 3 weeks is also a relative contraindication. History of ischemic stroke, dementia, internal bleeding within 2 to 4 weeks, non-compressible vascular punctures, pregnancy, active peptic ulcer disease, current therapy of anticoagulants is associated with an elevated INR higher than 1.7 or a prothrombin time longer than 15 seconds. So when there's concurrent therapy on anticoagulants, it's also a relative contraindication. So this is what I have. Thank you. Hello?
All right, thank you so much, Fatima, for the interesting interaction. We hope
Kobe, we can't hear you. Are you still there?
Seems so Poppy have dropped out of the call.
Okay. So maybe someone should just take over from here.
Thank you, Chief Fatima, for the presentation. Quite interesting and I think Shalom will be using at a month or two. I want us to, if you have a comments and questions at this point, to move them up. Comments or questions? about that. My network said, since there is no vision for which is performed, so everybody understood the presentation well. But we still expect to get your slide. However, since that you think you really want to add anything for us on this presentation now before we consider going to the next one.
Sorry, I went off a bit. I received a call. I don't know. Um, it's, it's open. I think you can contribute. Kweki, how far are you there? Okay, if Kweki is not there, maybe he's busy. I think he's quite engaged. Is there any contribution from anyone? Dr. Gudia? Sorry, I was a little bit engaged. I got distracted. It's a call.
Asked earlier, good evening, Chief, but seems nobody had any comments. So we may have to move on to the next one. One respective, I want to start about the lives.
All right, is there anybody here with that is prepared for his or her part? Dr. Tunji said he will take his tomorrow. Is there anybody available? Dr. G will join us much later. He has a presentation to make with his team. So is anyone available to take his or her part? Dr. Babalawa, I reposted the stuff on the group. I don't know if you saw it.
Okay, yeah, I saw it, but I'm yet to open it, but I'll go through it later. Thank you.
All right, sir. Thank you so much, sir. So is there anybody? Let me just go through the names. If there's anyone that's available, you can take it. It seems Chuka, over to you. How has COVID-19 contributed to morbidity and mortality of cardiovascular patients?
Thank you, sir. Unfortunately, I have not completed the slides, which I was hoping to take to, but something like the last question, I thought being the last that others should be ready, so I was planning to take it tomorrow.
Okay,
seeing that it was the last, but it seems that I was wrong. I should have completed the slides and taken it today.
Okay, no, it's fair. It's fine. It's fine. I think most persons actually will be ready by tomorrow from the fillers from the house. Let me ask Dr. Dom Auna. Dr. Dom, you're called to see a patient in the emergency room with breathlessness. How would you confirm that the patient's symptom is due to acute pulmonary edema?
I'll also be ready with that presentation tomorrow, please. Today was just too scattered for me. Yeah, but I have that in mind.
All right, thank you so much.
Thank you.
So what's the surgical? Dr. Olaoge, what's the surgical alternative? Surgical alternative to transvenous spacing?
Chief, I read it tomorrow.
Okay, sorry. Oh my God, sorry. I didn't. Sorry. You told me. So it seems there is no other person ready. Maybe we'll get the slides of Dr. Jacqueline, Dr. Okogun, and Dr. Fatima maybe tomorrow, and they will be ready for tomorrow. Dr. Chuka, what do you think we should do next?
I wish I knew at this point in time, considering that maybe I would have finished mine and then use that somehow to can I consider the possibility that we have to use it. Well, whatever you decide, I'm okay with it. Because I don't think any other person is ready to present, and then I don't think we honestly go back to the MCQs, which I don't know how good they are, but they are close. Otherwise, I think we have to work on start doing everything tomorrow. I think the way things are going, the question there is some that I actually finish the whole of the questions tomorrow because they don't take time. As you can see, the one I've done already, there are things we can run down fast. We can actually finish the rest of them tomorrow and move on to the next one by next week. Just to make that everybody should be ready to talk. At least I even me making myself straight. So I think on the phone, I won't give it to you, I'll start talking.
What? So you said
Hello.
Yes, sir.
I have a suggestion. Is it possible to take some of the MCQs that some people are ready with rather than doing nothing? Since we cannot continue with the orals.
Yeah, it's a good suggestion. Let's take MCQ and cover some ground. For me, I think Dr. Kogu, you were ready with your MCQ the other time, so we can take it. Whoever is ready, Fatima, if you're ready with yours.
Yes, I'm ready also. So after Dr. Kogu, then I'll do mine.
No, sorry, Dr. Fatima, I think you can. I'm driving already.
Okay.
All right, so let me take mine. All right.
All right.
I don't know if someone will project the question so that everyone will be carried along.
Over to you, Dr. Shuka.
If you can project, I think with the questions, so you have your system.
Ima is, I think Ima is not available. He's busy with something. Who can help us? Gogo is on his way. Okopi, can you help us project? Chief Okopi. Fatima, just go ahead. Everybody understand there are basic questions that we can follow. Please, I think you should just
I'm trying to do that. Maybe I'm trying to use my phone. Just continue.
Okay, so my questions are 36, 37, 38. Question 36 reads, a young man took cocaine and later developed chest pain. Which drug will you not give? So going straight to the answer, the drug I will not give is beta blocker. So now what's the explanation behind cocaine use in causing chest pain? So the commonest cocaine-related cardiovascular problem is chest pain, with 57% of admitted with 57% of patients having this been admitted into the hospital. And cocaine can cause myocardial ischemia and consequently acute coronary syndrome. The mechanism behind this is that it blocks the uptake of norepinephrine, thereby leading to alpha and beta adrenergic effects, consequently leading to increased heart rate, tachycardia, and elevated blood pressure, and also vasospasm, thereby causing decreased oxygen delivery and thereby myocardial ischemia. So cocaine also, in addition to that, it also activates platelets, thereby causing increased platelet aggregation and potentiates thromboxane production, leading to thrombus formation. So this is the mechanism by which cocaine causes myocardial ischemia and acute coronary syndrome. By enhancing alpha and beta adrenergic effects, causing vasospasm, and also causing platelet aggregation and thrombus formation. So these are three pathways. Other cardiovascular complications of cocaine use include arrhythmias, atrial and ventricular arrhythmias, cardiomyopathies, myocarditis. Cocaine use can also cause stroke, endocarditis, as well as aortic dissection. So how do we manage cocaine-related chest pain? Management is by use of benzodiazepines. Benzodiazepines will decrease the blood pressure as well as the heart rate. Then the use of aspirin. Aspirin will prevent, is an antiplatelet agent. Then nitrates. Nitrates will cause vasodilatation. So these are the first line medication, the three first line medications in management of cocaine-related chest pain: benzodiazepines, aspirin, and nitrates. The use of beta blockers has been found to be deleterious and should be avoided because it may worsen vasospasm by permitting unopposed stimulation of alpha receptors. And the use of thrombolytic therapy is highly controversial. It is restricted for patients with continued evidence of MI, despite first-line medications mentioned earlier, and when immediate PCI is not available. So primary PCI is a safer approach in patients with definite myocardial ischemia, especially in the presence of cocaine use complications like severe hypertension, seizures, intracranial hemorrhage, or aortic dissection. So this is what I have for this question. Any additions? Can I go ahead?
So, Dr. Fatima, just keep hiring on. Anybody that wants to contribute would Abdulrazak, your network is really interesting. I don't know.
So question 37 reads, a 36-year-old bodybuilder.
Dr. Fatima, if the question said that, which drug will you not give to the man? Maybe if this current exam now asks, which drug will you give to the man? Please, which one?
Benzodiazepine, aspirin, and nitrates are the first line medications to give.
Thank you. Thank you.
Yeah, you're welcome. So aortic dissection. The next question is about aortic dissection. It reads, a 36-year-old bodybuilder with features of aortic dissection who presented with upper limb pain and later admitted to the A&E. Admitted ingesting cocaine, which is the least likely cause of the patient's problem. So this is a patient that came with features of aortic dissection, and there is history of cocaine ingestion. So looking at the causes of aortic dissection, already he is taking cocaine. So cocaine could be a cause of aortic dissection in this young man. So other causes of aortic dissection, in fact, the etiology can be grouped into congenital causes and acquired conditions. So the congenital causes which are possible in this young man include Marfan syndrome, Ehlers-Danlos syndrome, annulo-aortic ectasia, familial aortic dissection, adult polycystic kidney disease, Turner syndrome, Noonan syndrome, osteogenesis imperfecta, bicuspid aortic valve, coarctation of the aorta, connective tissue diseases like SLE, metabolic disorders like homocystinuria, familial hypercholesterolemia. So these are congenital causes of aortic dissection. Acquired conditions that may risk a patient to have an aortic dissection include hypertension, pregnancy, syphilitic aortitis, deceleration injury possibly related to chest trauma, as well as cocaine use. So cystic medial necrosis, as we have known, is a degenerative change leading to breakdown of collagen and elastin and smooth muscle cells in the intima, media, and adventitial walls of the aorta. And this is the pathway by which Marfan syndrome causes aortic dissection by causing cystic medial necrosis. So looking at these causes, a young man may have all this, with the exception of atherosclerosis. Atherosclerosis is not likely, is the least likely cause of aortic dissection in this man. A is Ehlers-Danlos syndrome, B Marfan syndrome, C or atherosclerosis, and D bicuspid aortic valve. So my answer here is atherosclerosis. Sorry, there are other, I also have iatrogenic causes of aortic dissection. They include aortic valve and mitral valve replacements, coronary artery bypass graft, percutaneous catheter placement, e.g. cardiac catheterization, percutaneous transluminal coronary angioplasty. So I don't know if there are contributions or I should move on. So question 38. Sorry, 39. This question on aspirin resistance was answered last time. So question 39. Commonest route of permanent pacemaker. A, transjugular, subclavian, and external jugular vein. So pacemaker is usually inserted by transvenous approach, and the commonest route is subclavian vein, followed by cephalic vein, internal jugular vein, and femoral vein. This last two rarely used. So the commonest route is subclavian vein, followed by the cephalic vein. So permanent pacemaker placement is considered a minimally invasive procedure, and transvenous access to the heart chambers under local anesthesia is the favored technique. The pacing generator is typically placed subcutaneously in the infraclavicular region. However, occasionally, pacemakers are implanted surgically via a thoracotomy and the pacing generator in the abdominal area. So looking at complications of pacemaker, I think it is possible, since it is related to the pacemaker. Just to mention few, we can have access-related complications that can be early or late. The early complications include bleeding, hematoma, phlebitis or thrombophlebitis, local infection, arterial injury, hemothorax, pneumothorax, catheter-related thrombosis, which can lead to pulmonary embolism, air embolism, dysrhythmias, atrial wall puncture. Someone can puncture the right atrium, anaphylaxis, or chylothorax. Late complications include hematoma, venous thrombosis, phlebitis, arteriovenous fistula, hemothorax, as well as infection. So pocket-related complications include swelling, hematoma, bruising, and local pain, infection also. Late pocket-related complications include pocket erosion, pocket infection, or chronic pain at the site. You also have lead-related complications, which include atrial or ventricular arrhythmias, chamber perforation, pneumothorax or pneumopericardium, intercostal or diaphragm pacing, lead dislodgement, cardiac tamponade, hypotension, and bleeding. Endocarditis is also a possible complication. So what about the pacemaker-related complications? The pacemaker-related complications can also be early or late. The early include infection. So infection can occur at any time, either early or late. Then malfunction, which could be under-sensing, over-sensing, loss of capture, loss of output, inappropriate mode, inappropriate rate, pulse generator failure, pacemaker-mediated tachycardia, pacemaker syndrome. Late complications include late pacemaker-related complications, tubular syndrome, pacemaker infection, pacer malfunction, allergy or sensitivity to the device materials. So this is the end of my session. Thank you.
Dr. Fatima, thank you so much for another detailed presentation. This pacemaker presentation, I don't know if you can make a small slide with what you just said for us, in addition to your orals. Very, very, very interesting. I don't know if it's possible.
I will do that. No problem.
Sure. All right.
Dr. Fatima, please, can you come again with the routes? You said subclavian, cephalic, internal jugular, and
yes, the commonest route is subclavian vein. That is number 1. Then number 2 is cephalic vein. Number 3 and 4 are rarely used. Number 3 is internal jugular vein and femoral vein. So these last 2 are rarely used.
Okay, thank you.
Yeah.
So, Dr. G, we started with the orals, and most of us, we gave 3 of them: Dr. Jacqueline in myocardial biopsy, Dr. Okugun, resistant hypertension and refractory hypertension. Dr. Kweki contributed with respect to renal artery denervation in addition to the management plan he gave. He will share the slides. And also Dr. Fatima took part. So we couldn't get more. Most persons will be prepared by tomorrow. So we decided to go with the MCQ. So I just let me brief you up so that you can take over in case you want to take your part. So I don't know, were you prepared for the oral, or if you're not,
actually
you can continue the MCQ.
2 presentations back to back, with this my people. So I still Wednesday.
Okay, maybe tomorrow. Okay, tomorrow then.
I'll
tomorrow, so we can continue with the MCQ then.
Wednesday, but I'll try for tomorrow.
All right, sir. Okay. You say you share your slides of hypertension, pharmacokinetics, and then the one you did today.
No issues at all.
All right. So over to you, sir. You can take over.
So I think we'll continue with the MCQs. I don't know if there's any other person who's ready.
I thought Dr. Abrazak wanted to present his MCQs.
Is he on the Dr. Abdurazak, if you're ready, you can go ahead.
Okay, I think I did my yesterday.
Oh, okay.
I took question 27, 28, and 29.
Any other person ready? Okay, maybe I might just attempt one of my questions on aspirin resistance. We had discussed it, but I don't know, should I still go over it?
Yes, sir. Repetition is a mother of memory. You can.
Okay. Okay, so aspirin resistance, when we talk about aspirin resistance, is basically the inability of aspirin.
What question?
That's, I think, question 3. It's way up.
Okay.
Question, 6. So it's the ability, aspirin resistance is the inability rather, or failure of aspirin to produce an expected biological response, or the failure of aspirin to prevent antithrombotic events. Another way you can define it is the inability of aspirin to suppress platelet function or suppress the production of some of the metabolites or molecules that bring about antithrombotic effect, particularly thromboxane A2. Now, for us to understand this, I think it's a need to talk about the arachidonic acid pathway, which produces thromboxane. So we know that arachidonic acid is derived from membrane phospholipids. We have phospholipase A2 acting on the membrane phospholipids in various cells producing arachidonic acid, which will either go through the COX or the 5-LOX pathway, that's the cyclooxygenase pathway, or the 5-lipoxygenase pathway. Now, the LOX pathway usually occurs in leukocytes, and it produces leukotrienes, which, as we know, is pro-inflammatory. Now, the COX pathway either happens in platelets, or rather occurs in platelets, it occurs in endothelial cells, and can also occur in vascular smooth muscles. So in platelets, via the action of the COX enzymes, that's COX-1 and 2, in platelets, it gives us thromboxane. And then we know that thromboxane is what is pro-thrombotic, is pro-inflammatory, and is vasoconstrictive. Now, in the endothelial cells, the COX pathway will give us prostacyclin, which does the direct opposite of what that pathway gives us in the platelets. So if you remember, we know that endothelial cells usually they say it has how do you call it, antithrombotic and anti-inflammatory effect. It's basically countering what the platelets do. The platelets are pro-thrombotic because if there's an endothelial damage or bleeding or something of that sort, of that nature, it wants to control that bleeding. So it's pro-thrombotic and it's also vasoconstrictive, while prostacyclin produced via the same arachidonic acid pathway is antithrombotic, anti-inflammatory, and vasodilatory. In the smooth muscles, I wouldn't bother so much about that one. So in the platelets, the arachidonic acid, like I said, produces thromboxane, which will give you these things I've mentioned. So now, having this in mind, scientists came up with a wonder drug that could, counteract the effect of thromboxane. And it's been shown that the use of 1 tablet of, a drug that inhibits this thromboxane, that's aspirin in this case, reduces the risk of cardiovascular morbidity and mortality by at least 25%. So it has been there over time. I can't remember when it was developed, but people have been using aspirin for quite a long time and it has been effective. So if this aspirin, for whatever reason, fails to suppress the platelet action or production of thromboxane, you say it is aspirin resistance. Now, you can assess aspirin resistance by actually assessing platelet function. And that can be done in the lab. There are several things one can do. You have flow cytometry, you have genetic testing. There are some tests you do for platelet aggregation. I can't remember the name right now. And then there are even recently point of care machines that people can use to assess for, if there's adequate suppression of platelet function by aspirin. From what I even saw online, patient comes in, you are suspecting aspirin resistance, there are point of care machines, you just take your sample, put in, and to tell you if that aspirin is actually suppressing the platelet function. So from there, you can actually make a diagnosis of aspirin resistance. Now, the causes of aspirin resistance can be divided into clinical, pharmacological, and genetic. Now, in terms of the genetic, you have polymorphism of the COX-1 enzyme, which we know is involved in the arachidonic acid pathway that produces thromboxane. And then also polymorphisms in other genes that are involved in thromboxane synthesis. That is for the genetic. Then for the clinical, it's either the patient is non-compliant with medications or there's an increased turnover of platelets. Any condition that brings about an increased turnover of platelets will lead to an excess amount of thromboxane, and whatever dosage of aspirin you are giving might not be sufficient to suppress platelet activity. Then the other one again is if there's an upregulation of non-platelet sources of thromboxane. For example, thromboxane can also be produced by macrophages and sometimes by endothelial cells. So if there's an upregulation of this non-platelet sources, this could also lead to aspirin resistance. Then for the pharmacological, it could either be as a result of inadequate dosing or if there are drug interactions. So basically, the management of aspirin resistance is to identify, if possible, and treat the cause of the aspirin resistance, or you change to another drug that also suppresses platelet function, because we know it's not only aspirin that can suppress platelet function, but there are several other drugs. So that's basically how you manage aspirin resistance. So that's all for question 6. I'll take 7 and 8 on subsequent days.
Thank you. I didn't know if you come across anything like the adherence to the medications too, as some interpret it as a cause of resistance. I don't know if it's part of, since you mentioned that, even drug adherence also.
Yeah, I actually mentioned, well, I said non-compliance though. I don't know if it's the same thing we're referring to.
Okay, thank you.
Well, technically, I think some people really don't want to refer to non-compliance as the cause of aspirin resistance. Of course, if you don't take your medications, then the action of thromboxane and platelets is going to continue. So would you really call that aspirin resistance? In aspirin resistance, you are actually giving the medication and it's not working. When non-compliance, the patient is not even taking the drug. There's a term they use for that. Some literature are using another term for that. For patients who are non-compliant, they actually are not referring to it as aspirin resistance. Maybe when I check again, I can't remember what it's called. But when I check, I'll send it to the group chat. But in some other literature, they put non-compliance as a cause of aspirin resistance.
Okay, well done, sir. Dr. Ima.
Yes.
Sorry, you said the genetic cause, you said polymorphism to
of COX1
to COX1 gene.
Yes.
And what again?
They said other genes involved in thromboxane synthesis.
Okay, so I don't know, because since the effect of this COX1 gene, rather for COX1, is on both platelet and the endothelial cells. And you said that the endothelial cell function just opposite the platelets. So don't you think that inhibiting it will produce effect that is counteracting each other? Because if the endothelial cell was supposed to produce prostacyclin, which help in thrombosis and also help in vasodilatory effect and also anti-inflammatory function. And then you are inhibiting those functions. Then you now have a platelet that cannot be able to produce the prothrombotic vasoconstrictive effect and pro-inflammatory. Don't you think they will counteract themselves? I don't know.
The answer here is that the action of aspirin is dose dependent. Now, for the inhibition of thromboxane in platelets, it occurs at a dose of 40 milligrams. Now, for you to have effect of aspirin in the endothelium, that's on prostacyclin, is from a dose of about 80 and above. And I guess that's why in day-to-day prescriptions, we give aspirin at 75 milligrams, because 75 milligrams, it will only inhibit platelet function, but not prostacyclin in the endothelial cells. I guess abroad, they use about 81 milligrams thereabouts. I'm not so sure, is it 80 or 81? When people come from out there, they bring aspirin at about 80 something, I think 81. So by the time you go above 80, 81, it now has an effect on, the arachidonic acid pathway in the endothelial cells. So for prevention of thromboembolic events, at the doses we give in clinic, it's only going to inhibit platelets and not prostacyclin. And that is why even in aspirin resistance, it's not advised that you should go above, the usual dose. They said there's really no effect and no need for it to go above, the regular doses we give.
Okay, thank you.
Okay, so any more comments, or is any other person ready? So should we just call it a day and then reconvene tomorrow? I think it will be faster if people prepare.
I think we should call. I think we should call it a day
tomorrow, and we'll run through the orals tomorrow, and then hopefully finish this one up on Wednesday.
I think we should call it a day, Dr. G, and and see tomorrow, so that we'll be ready tomorrow and run a marathon to 11.
Is tomorrow going to be the orals or the MCQ?
No, orals.
Dr. Godia, we agreed.
Tuesday
and we agreed the orals.
available, we take them.
Tuesday and Wednesdays we'll do the orals. We will do the orals as agreed, Tuesdays and Wednesdays. If we finish the oral, any other team more, we can take MCQ by tomorrow.
Okay, sir.
Yeah.
Meanwhile, I'm still yet
Dr. G, over to you.
I'm still yet to get the oral for the last exam. Even though I spoke with one of our senior colleagues, he told me things that came out. So if I can't get it, then I'll probably just list out the topics that came out, and then we can just read around them.
That will be fine.
But nobody seems to have the recall.
Okay. That'll be fine. Dr. Kochi, I'll find good news.
If I remember, she said the questions came out on the role of cardiologists in, I think, cardiac surgery. Question came out on valve.
Is it not Ugo exam and others?
Yes.
I guess if you want to get a recall, you should know. Get the recall. I don't know. I will get a recall. I don't have any right now, but I think we should be able to pull out the recall. I understand that they said it was not the clinical stuff. They were just asking questions directly. Yeah, I'll reach out to some of them.
Okay.
It's all right. I think that our time is almost there. 4 minutes to time. So I think we can call it tonight. Please, on Friday, let's remember dissertation presentation. Please, that's part of the stuff. Let's not forget to be working on our dissertation. It's so it's part of the exam too. All right, so from my end, congratulations to all the exam candidates. Timetable is out. So a few weeks from now will be the exam. Congrats.
Thank you.
So that'll be all for me, Dr. J.
Okay. So in the absence of further comments or announcements, I think we can call it today and reconvene tomorrow. Dr. Chika, I beg, hit me up. What's up?
But I didn't get you.
Concerning what we discussed yesterday.
Okay. I'll put up something on WhatsApp, sir.
Oh, okay. Yeah, good night, everyone.